Uh, Good evening, everyone. My patient, Mrs. Veena Malik, 66-year-old female from Rajendra Nagar, New Delhi. She is graduate by education and housewife by occupation. She presented with complaints of pain in the left knee for 2 years, stiffness and altered gait in the left knee for 6 months. History of presenting illness. My patient was apparently well and asymptomatic since 2 years back when she developed pain in left knee, which was insidious in onset, gradually progressive, more in the morning, aggravate on walking and getting relief from taking rest. Stiffness and altered gait since 6 months, which is restricting her routine activities. There is no history associated with fever. There is no history associated with other joint pain. There is no history associated with trauma. Uh, Past history: the patient is known case of hypertension for the last 10 years. She is on regular medication. She is taking tablet telmisartan 40 mg OD. A general physical examination. Patient is examined in sitting position, conscious, oriented to time, place, and person.
Rashid, you talked about the medications. She's non-hypertensive and she's taking telmisartan. Is she taking any other thing also?
Ma'am,
and she's got stiffness of the knee joints.
ma'am, she was taking non-steroidal anti-inflammatory drugs on and off when having pain.
Okay.
Conscious, oriented to time, place, and person, sitting comfortably. Her weight was 64 kg, height was 60 centimeters, which was her BMI 25 kg per meter square. There is no pallor, icterus, though no cyanosis, clubbing, pedal edema, and no lymphadenopathy. She is afebrile. Pulse rate was 86 per minute. Right radial artery, adequate volume, normal characters, normal condition of vessel wall, no radial and no radiofemoral delay. All peripheral pulses were palpable. Blood pressure was 130 by 80 millimeters of mercury in right arm sitting position. Entry rate is 15 breaths per minute, regular, non-thoracic. Airway examination, she is examined in sitting position. There is no visible craniofacial deformity, no use of accessory respiratory muscles. Mouth opening is more than 5 centimeters. Modified Malapathy grading is 2. No buck teeth, no loose or missing teeth, or artificial dentures. Airway, TM distance is 7 centimeters, HM distance is 6.5 centimeters, sternomental distance 13 centimeters, thyroid distance 2 centimeters, neck range of motion is adequate, neck circumference 31 centimeters at the level of thyroid cartilage. Respiratory examination: on inspection, the chest is well shaped, trachea appears to be in center, no suprasternal and intercostal recession. Bilateral chest wall movements appears symmetrical during respiration. No use of accessory muscles seen. No audible wheeze or stride. No dilated veins or pulsations or scars over chest wall or back. All the findings of inspections are confirmed on the palpation. Chest expansion is bilateral, symmetrical. No tenderness or bony deformity. Chest expansion on full inspiration is 5 centimeters. Tactile vocal femoris. Ma'am?
Yeah, I wanted to know, like you said, you did the airway examination and you found it to be all right. Is there any particular name, when you are, because airway, as anesthesiologists, we all know that airway examination is very, very important. So, any particular test you have not done? For the neck movements, no, any particular test that could have been done? And when you are, doing the airway evaluation, like the airway foundation, which is based in Delhi, also they have done a very good work. So whenever you are assessing the airway, whether the patient undergoes general anesthesia or regional anesthesia, as anesthesiologists, we all know that it is very vital to do an airway examination. So, see, this upper lip, bite test is very, very important.
Upper lip bite test is
that is a good, sensitivity and specificity, so that should be there. And this, when you look at the patient, you see the symmetry of the face, everything, and then you ask the patient to open the mouth, you do the Varan putty, and so there's no this line of sight examination. Okay. And coming to the respiratory system, and then did you find anything, Positive, any positive point?
No, ma'am.
Respiratory, abdominal?
No, ma'am.
No. Okay. Then what else in the examination?
Ma'am, all the all the systemic examinations apart from the spine examination of the spine and local examination of the knee.
What about the nervous system? About the level of
So
what is it's important that you should be examining a patient, elderly patient coming for surgery for this major surgical procedure. What you should be ruling out.
sorry, ma'am. Uh, Ma'am, can you repeat the please question, ma'am, please?
Elderly patient coming for a major surgical procedure. No. So when you talk to the patient, you found like what must be ruled out. Like you did say that the patient is not on any medication, but the cognition is very, very important. No.
Cognition is her mental status, ma'am, very important because in the geriatric patients most after post-operatively they are more prone to for post-operative delirium. Uh, uh,
So
and
yeah, yes, it is very, very important that you assess the cognitive status and other, frailty must be ruled out because again, that is an indicator that the patient may have post-operative morbidity. These two, three things are very important. Now coming to the spine examination. So you tell me about the spine examination.
ma'am, spinal examination, there is no redness, swelling, or any other scar marks present on the skin. No obvious gross deformity, normal curvature of the spine, and intervertebral spaces well felt on the palpation.
So what do you expect in an elderly patient, the spine examination? What are the usual problems?
Ma'am, in the elderly patients, the most of the joints are the intervertebral spaces will not felt on the palpation or and there might be the ligaments are hardened and the spaces might be diffused uh, uh, and
Had an altered gait, altered gaits. There could be changes in the spine. There could be, as you said, the ligaments are ossified. You may have difficulty in palpating the intervertebral spaces, and there could be some element of kyphosis or scoliosis again, which makes the regional block a little difficult. No, because changes or other changes, age-related changes, they can occur in the spine also. There could be stenosis, spinal stenosis, or there could be ankylosing spondylitis or other problems. So it is important that you do a very good spine examination. Okay. So what next?
Ma'am, local examination. Ma'am, on inspection, there is no redness, tenderness, or skin changes. The range of motion is restricted. On palpation, findings of the inspection confirmed. There is no warmth over the skin of joint and mild swelling on the medial side of the knee. Uh, and provisional diagnosis. My patient, 66-year-old provisional diagnosis is 66 years old female patient with osteoarthritis. She is known case of hypertension on regular medication is posted for total knee replacement.
Ashim, why do you say that it is osteoarthritis?
Ma'am, because I had ruled out uh, an history of trauma, and there was no history of any septic arthritis. There is no history of any other negative pseudoarthropathies. There is no history of any rheumatoid arthritis, no other joint involvement also, ma'am. So, that's why I think it is osteoarthritis age-related change, ma'am.
Okay, so what about the investigation? How do you proceed with the investigation of this patient?
Ma'am, I'll order him see complete blood count for hemoglobin, platelets, for renal function test, ma'am, because she was taking non-steroidal anti-inflammatory drugs on and off, and she's hypertensive also, and serum electrolytes, and ma'am, ECG, chest X-ray, and 2D.
Okay, okay. So you tell me, why do you want the hemoglobin done or the counts done in this patient?
Ma'am, because because of the blood loss, ma'am, the surgeries and to assess the baseline hemoglobin, one one should know before the starting of the surgery.
Okay, because this patient might bleed also. But as of course, in the exam, we will not be getting these reports, but in the elderly population, and India is quite common. And in the elderly, usually undergoing major surgery, we advise these days we advise serum albumin also. Okay, and counts, total leukocyte counts.
Ma'am, to rule out any infection, ma'am, infective causes.
And okay, and as I see that this patient is hypertensive, and you advised 2D echo. So, do you normally do 2D echo for all hypertensive patients? What are the indications? Why did you
Ma'am,
recommend?
ma'am, 2D ma'am, indications are like any documented ischemic heart disease with reduced functional capacity less than 4, and unexplained shortness of breath in the absence of clinical signs of heart failure, murmur in the presence of any cardiac or respiratory symptoms, murmur in any asymptomatic individual in which in whom clinical features or other investigations suggest some structural or any other heart disease, ma'am. These are the indications of 2D echo. But in this patient, ma'am, I ordered because she's a geriatric patient and with restricted mobility, so there is a difficulty in assessing the her cardiopulmonary functional reserve, ma'am. And just
Yeah.
and to rule out or other valvular deformities and other this way. That's why, ma'am.
Okay, so remember that in elderly population, normally, I mean, echo, we are really not, we should not be doing that often, unless the indications in Rashid talked about it. So, but in elderly population, because you cannot assess functional status, so many times we advise 2D echo, and her chest X-ray was normal, and
Yes,
any
ma'am.
other testing you got it done?
Uh, no, ma'am.
Did you do any test for coagulation? I think you did, no? Coagulation.
PT INR, ma'am. INR, ma'am.
That you got it done. Any other tests which may be required?
Ma'am, on viral markers, ma'am.
Okay, not, I mean, in our country, not really not routinely done, but yes, no harm. But I mean, this practice will vary from institution to institution. And at times, the X-ray spine is also done. So that you can see that places that because the regional block is a bit difficult in elderly patients. So, like in my institution, we routinely get it done for elderly patients, where you really want that the regional is going to get the benefit the patient, and you want to go all out for a regional block. So there is no harm in getting X-ray spine also done. Okay. So based on these investigations and clinical history, now this patient has come to you. She's osteoarthritis and she has come to you for a unilateral total knee replacement.
Yes, right.
And so how will you manage this patient? What are your, the challenges you're going to face for this case?
Ma'am, as she is a geriatric patient, so there is a low functional reserve. There is no functional reserve, and I will be evaluating her cognition status earlier. She's hypertensive. She's on taking regular medications. She has a history of associated with intake of NSAIDs for pain. Preoperative mobility as the mobilities was restricted. She was not able to perform her even her routine activities. So there might be DVT. Pain management, ma'am. Pain management is a concern in the genetic patients also, ma'am. In intraoperative and postoperative pain management, blood loss, and ma'am, embolisms and like bone cement implant syndrome, postoperative delirium, and early mobilization, especially with capital and urinary catheter if there is. These are the concerns, ma'am.
Okay. So, I mean, out of these anesthetic concerns, I mean, which is a very, serious problem, though it doesn't occur more often, but you are concerned about it. One serious complication associated with these procedures only. You laid out, several anesthetic concerns.
Yeah, ma'am, bone cement implant,
Bone cement, implantation
implant
syndrome.
syndrome.
So that is, going to be, something very special to this procedure. Any other procedure where, this bone cement implantation syndrome can occur, rather, there the incidence is higher as compared to knee joint replacement.
Arthroplasties and hip replacement also.
Hip arthroplasty and other procedures. Okay. So, what about this? How do you achieve, the DVT prophylaxis? What do you do for that? I mean, elderly patients, uh, patients especially who are, like this patient is mobile, but there are patients who are confined to bed, and there the incidence of it is a serious problem. Or the patient coming for cancer surgery. So, how do you achieve it? What are the different ways you provide DVT prophylaxis?
Ma'am, different ma'am mechanical compression stockings, ma'am, by mechanical methods, and subcutaneous low molecular weight heparin 0.6 mg ma'am, OD 0.6 units, which we are giving here, ma'am, in our institution.
No, what did you say, Karen? What do you give?
Low molecular weight, ma'am.
Okay, and what else? Some new modality has
And
also been added recently.
uh, ma'am, compressive stockings, ma'am.
So you can divide them, okay, mechanical, you said, stockings and all that. And then, of course, the pumps during the intraoperative period. And then the
Attic,
preoperative, the pharmacological ways. So you did say, you
pharmacological.
talk about the drugs. Any other oral, modality which has been added, which is becoming popular and has advantages over this unfractionated heparin?
Ma'am, fondaparinux, ma'am, and anti-10A inhibitors, ma'am.
That's injectable. I'm talking about oral drugs, new drugs which have come up in the market.
Uh,
Have you heard of those newer oral anticoagulant drugs? There you don't have to monitor. You're not much worried about the bleeding part. They do not cause much bleeding, and the patient compliance is also good. The oral anticoagulants, we read about them.
sorry. Yes, ma'am.
So whenever you are, all these patients in the preoperative area, in the preoperative setup, you pick up any abnormality, you try to optimize the patient's condition. So there's a term for that. What do you call it? We always lay great stress on,
Ma'am,
preoperative preparation of the patient.
ma'am, prehabilitation, ma'am.
Prehabilitation, and that is a part of IRAS, which we enhance recovery, after surgery and all that.
Enhanced recovery
So,
possible.
so we are, trying to apply it in several kinds of surgery. Of course, it came with, for this was initiated initially for patients who are undergoing colorectal surgery. Okay, so pain is again, I mean, very post-operative pain relief is again a very important area in this patient. So, what are your what goals you have in mind for these patients? Okay,
Ma'am,
what are the goals? Yes.
ma'am, goals, ma'am, pain management. Ma'am, pain management, I'll be using multimodal approach and blood loss, ma'am, and post op delirium,
Yes.
ma'am,
Yes.
and uh, she's on medication, so I already on hypertension medicines, so her other blood control, blood pressure, and ma'am, apart from that, embolism, ma'am, because of we are applying, they'll be applying tourniquet in the and
Okay,
cementing.
Okay, Rashid, now this patient is scheduled for surgery. So how do you go about it? You
Okay,
examine the,
ma'am.
yes.
Ma'am, I'll evaluate this patient preoperatively and then explain the procedure to the patients and relatives. Different approaches are there, like renal anesthesia and general anesthesia. I'll be advising combined spinal epidural because post-operative pain management, epidural catheter will be there. I'll be ordering NP orders for 8 hours for solid food and 2 hours for clear fluids. Written informed consent. Ma'am, send BGCM and DVT
What is
prophylaxis as per.
BGC?
Ma'am, sorry,
What is
ma'am,
BGC?
blood group cross matching, ma'am. Sorry, ma'am. And continue antihypertensives on the day of surgery, ma'am. Tablet alprazolam 0.25 mg HS and tablet pantoprazole 40 mg on the day of surgery, ma'am.
So this patient is on AC inhibitor. Tell us that. Tell me that. No? So, are there any concerns about this group of drug? Would you like to give? You said that you would like to continue this antihypertensive on the day of surgery. Tell me certain.
Yes, ma'am. Ma'am,
Ah,
uh, because ma'am, as ACE inhibitors and angiotensin receptor blockers, uh, in
yes.
they block they block via the vasoconstrictive actions on the angiotensin too. Uh, so the in the intra there is a concern regarding that blood the blood pressure falls. If the blood pressure falls, then very potent vasopressors might be required for uh, uh, but uh, some authors say ki we can continue this on the day of surgery, and some institutions avoid. They said ki we can stop 24 hours before surgery.
So what you are going to do is you are going to give the
Uh,
morning dose of this certain to your patient. Okay.
yes, ma'am.
Okay. Okay. So now your patient. So how do you proceed further?
Ma'am, in the OT, when the patients arrive, all the standard monitors were attached. Wide bore cannulas will be taken, preferably 16 and 18 gauge. Keep the patient warm and duty warm. Under all aseptic precautions in the sitting position, I'll be giving combined spinal epidural. The drug I'll
So
be
what?
taking,
Okay. What drug will you be choosing?
ma'am, bupivacaine 0.5% heavy, 10 mg, ma'am.
Bupivacaine? Okay. Would
We
you
can
like
take, ma'am.
to
Sorry, ma'am.
add? Would you like to add something to it?
Ma'am. Ma'am, 20 mics fentanyl, ma'am.
20 bikes?
Fentanyl, ma'am.
Fentanyl. Why do you want to add fentanyl?
Ma'am, because the effect of the uh, uh, anesthesia will be prolonged and uh, early, ma'am. The effect because it is a lipophilic drug, ma'am.
Mm. No, what will be the main advantage of giving adding fentanyl to bupivacaine?
Ma'am, prolonged
You
effect,
said
ma'am.
prolonged effect or something else? Bupivacaine has quite a long duration of action.
Early, ma'am. The effect will come early, ma'am.
Early onset.
Yes, ma'am.
Okay. What other drugs you can choose?
Ma'am, levobupivacaine, ma'am. It is less cardiotoxic than bupivacaine, ma'am.
Okay, so you can use levobupivacaine also. Okay, and how much of the catheter you are going to leave inside?
Ma'am, 8 centimeters, ma'am. 5.
Pardon?
8 centimeters, ma'am.
How much of the catheter you will leave inside the epidural space? 8 centimeter might be the depth. Is there any difference in obese and non-obese patients? Because see, you are going to give CSC because you want to provide post-operative analgesia. So how much of the catheter you are going to leave, that is also important. You leave about about 2.5 centimeter inside. But for obese patients, you must leave an extra 1 centimeter because otherwise it might come out. Obese patients, so you leave about 3.5. That point you should always remember. Okay. So what next? How will you? Proceed and how will you monitor the patient? You have given the CAC.
Uh, I'll be watchful for uh, uh, SpO2 saturation, oxygen saturation, ma'am, and hypotension, and I'll, apart from this, ma'am, I'll be in regular communication with the patient so that I can before know there is loss of consciousness or altered sensorium, uh, and
You said is important.
sorry, ma'am. Hello.
Why is it important? Why you said that you will keep in contact, you will communicate with the patient. No verbal contact will be there, and you will monitor the patient. Why concern about these factors?
Ma'am, in case if there is these are the prophylactic, these are the symptoms of uh, cement implant syndrome and embolism, ma'am.
Yes, and also high spinal block can also be there. Don't forget that, though you have
Uh,
given a small dose and all that, but otherwise that possibility over to spinal block that can also happen. So these are the areas of concern. And is there any grading for the this bone cement implantation syndrome? The
yes, ma'am.
severity of the problem?
Ma'am,
Yes.
there are three grades, ma'am. Grade one is moderate, in which the SpO2 is should be less than 94%, and hypertension should be less than uh, not hypertension is when the systolic blood pressure is more than fall in systolic blood pressure is more than 20%, ma'am. And
Okay.
grade 2, which is severe category, the saturation fall in the saturation is less than 88%, and fall in the systolic blood pressure is more than 40%. And there is third grade 3, in which the requirement of cardio pulmonary resuscitation is there. Yes, ma'am. Pulmonary collapse.
Okay.
These are the three grades, ma'am.
Okay. So before I would like to I like to add a few things. Before you start, these procedures, it is very, very important that, of course, these procedures are major procedures always done in good setups. So it is always better that these kind of procedures are in OTs with the laminar flow, because that reduces the incidence of infection. Of course, asepsis is very, very important, but this is also important that if you can do these procedures in OTs with the laminar flow. And this antibiotic prophylaxis also, you should never forget. For all, because all these cases are elective procedures. So now, according to the WHO guidelines, also safety this thing. So we give antibiotics, intravenous antibiotics, 30 minutes before surgery. Okay.
Yes, sir.
So these are two important points you should not be forgetting. So what is the what are the timings, when you should be extra careful, when this event can happen, say arrhythmia, hypotension, or bradycardia, or the patient may suddenly, this patient becomes unconscious. Any particular timings while doing these procedures, then you have to be extra careful. Like you are not going to leave the patient at all, not only your junior.
Ma'am, at the time of cementing, ma'am, and
Okay.
hello, ma'am, at the time of cementing, and after that also, ma'am, one should watchful for these events, ma'am.
Okay.
At the
And
at the time of tuning and
procedures are
deflection of.
usually done. Yes. So these patients, most of the temperature. So, of course, regarding, when you're putting the processes, you have to be very careful, and also when you release the total. Then again, you need to be very, very careful.
Ma'am, please unmute yourself, ma'am.
Can you hear me now?
Yes, ma'am.
Okay. So, do you think your patient will need blood transfusion?
Ma'am, blood transfusion, ma'am, the blood to prevent the blood loss, a tourniquet, a tourniquet application will be there, ma'am, and I'll be giving antifibrinolytic agents also, ma'am, like tranexamic acid, uh, because they can reduce perioperative blood loss substantially, and there is no need for transfusion of blood if and reoperation for the bleeding also, ma'am, if the prophylactically
So,
these are given.
are you using it routinely? Are you using routinely in your hospital?
Uh, Not in every case, ma'am, in which the blood loss is suspected, ma'am, then we'll give them tranexamic acid, ma'am.
You don't give it routinely. Okay. Any other thing before you put the cement? Intraoperative? Anything else you do?
Tourniquet ablation.
And anything else you do to reduce the problems before you put the cement, before you put the processes? Anything else?
Ma'am, injection hydrocortisone 100 mg, ma'am, we'll give here, ma'am, in our institution.
Okay. Okay. And are there any precautions that the surgeon should be doing routinely, when they are putting the cemented implants?
Ma'am,
Either for the arthroplasties or
ma'am, the reaming and the while uh, uh, while the suction, they use a suction catheter to drain out to drain the bone debris, marrow debris, uh, for the, yeah,
okay.
so that the intermedullary canal pressures will be lower on the lower side, and they ream the bones, ma'am, long bones.
Okay. And what kind of, how do they put the cement? I mean, they do it manually or with the gun. So is there any difference in the two procedures as far as, the incidence of this bone cement implantation is concerned? So this can be done, you can do it manually or with the help of the gun, and what the pressure achieved with the gun are almost twice as done, get with the manual placement. So there the pressure can be very high, and definitely the incidence of bone cement implantation syndrome can also go up. Okay. So the surgery is, done. Surgery is done now. The dressing has been done, and now you want to shift the patient to the recovery room. So how are you going to manage this patient, and where will your patient go
Ma'am, in the
post-operatively?
post-op care unit, ma'am, adequate hydration should be there, ma'am. In IV fluids at the rate 100 ml per hour, oxygen at the rate 5 ml per hour by face mask, and multimodal anesthesia for pain management, ma'am, DVT prophylaxis, and leg abducted to the prevent the implant displacement. Watchful for the post-operative delivery, ma'am, and
So you tell me about this post-op multimodal anesthesia. What are you going to give this patient? Just to name them, because Sakshi also to summarize the case presentation, and we don't have much time. Okay.
I had already placed the epidural catheter, so I'll be giving the infusion with 0.125% bupivacaine, 4 ml at the rate of 4 ml per hour.
Okay. And anything else you will be combining?
Ma'am, injection paracetamol 1 gram IV, ma'am. And
1 gram. You have to tell the route, the dose. No?
yes, ma'am.
That's how you give it.
Ma'am,
Intravenously, how frequently you will give?
ma'am, TDS, ma'am.
TDS. Okay. Okay. And do you keep them from the PACU? Where do you shoot the patient? Any specialized area in the hospital where you keep these patients?
Ma'am, post-operative care unit is there, ma'am, and there is an ICU for post-operative patients also, ma'am.
High dependency area, the patient could be either in the HDU or in the intensive care unit. And
Yes.
was very important. They may have small emboli going in, emboli, and you may find that the patients are desaturating, the saturation is not picking up, or they may have mild hypotension. So it's very, very important that you monitor them. Suppose the patient has, undergoes general anesthesia. So what kind of, how will you provide pain relief to this patient? I just want you to name the techniques. What you do.
Ma'am, we can give adductor canal block, ma'am, and there are hello, ma'am.
So what are the block canal? What can be the disadvantage?
Ma'am, adductor canal block, there is an advantage over the femoral nerve block, that it is that the quadriceps paralysis is not there in adductor canal block, ma'am, and so which can help in early mobility and uh, uh,
Okay, can you tell me something else? Other things, I mean, other block you can do.
uh, hello, sorry, ma'am.
You can give IPAC, you can give IPAC, or you
IPAC
can
block,
give
ma'am.
infiltration blocks.
Enter between popliteal artery and posterior capsular of the knee, ma'am. Block.
Okay, so that you covered that small area which is supplied by the sciatic nerve. So thank you, Rashim, and now I would like to invite Dr. Sakshi to summarize the case, give the salient points. Dr. Sakshi,
Thank you.
please.
Good afternoon, ma'am.
Thank you. Yeah, Sakshi, I want you to cover the salient points which Rashim has placed.
Rashim, stop sharing your screen now.
Okay.
Good afternoon, everybody. So I would like to summarize the topic, total knee replacement. To start, TCAR is a common orthopedic surgery which is performed in geriatric patients. It is safe and highly effective procedure to improve mobility and patient quality of life. As the population, surgical techniques have evolved over time, so have the anesthetic techniques used for these procedures, resulting in improvement in patient outcome. Knee joint is a hinge joint between lower end of the femur and upper end of tibia. The ends of the bone are covered by a layer of cartilage, which allows for the smooth movement. When this cartilage is damaged by arthritis, joints become stiff and painful. Most commonly, these patients have osteoarthritis. The other conditions which require knee replacement include rheumatoid arthritis, knee injury, and gout. Joint replacement is usually performed to relieve pain and improve mobility, and the surgery usually takes around 60 to 90 minutes. Our basic anesthetic concerns in these patients will be, these patients are usually geriatric patients, and therefore these patients can have common associated problems like hypertension, IHT, or renal impairment. Then second point would be osteoarthritis related symptoms. Thirdly, our patient is hypertensive patient, so these patients are on antihypertensives for a prolonged period of time. Therefore, renal impairment should be looked out for. Previous history of medication for pain like NSAIDs, preoperative immobility, difficulty in positioning for regional anesthesia, difficulty in assessment of exercise tolerance due to restricted movement, and DVT prophylaxis. Intraoperative concerns will be patient positioning for regional anesthesia. Since these patients have stiff joints, positioning might be difficult. Blood loss intraoperatively, which can be minimized by the use of tourniquet and use of antifibrinolytic agents like tranexamic acid in the dose of 10 to 15 mg per kg. Intraoperatively, hypertension will be our concern in these patients since our patient is a known hypertensive. Bone cement implantation syndrome, which is usually seen during placement of cement or the prosthesis, and is usually diagnosed by patient having hypoxia, hypotension, cardiac arrhythmias, or sometimes can also end up in cardiac arrest. Fat embolism. Anesthetic technique. There are various anesthetic techniques which can be used to perform this surgery. Most commonly used technique is regional anesthesia, which can include subarachnoid blockade, combined spinal epidural anesthesia, peripheral nerve blockade. The other techniques which are used are periarticular injections and general anesthesia. Regional anesthesia is usually preferred over general anesthesia because it can provide better pain relief. There is decreased propensity for blood loss. There is less chance of DVT or pulmonary embolism. And also it's easy to detect these things. There's better pulmonary function post-operatively. It can provide good post-operative analgesia. There's reduction in surgical infections, early ambulation and discharge, and it's also inexpensive compared to GA. The other anesthetic technique which can be used for TKR surgeries is peripheral nerve blockade. In case of peripheral nerve blockade, the benefits are the quality of analgesia is equivalent to epidural and superior to opioids. There's less chance of hemodynamic instability and urinary retention. Preservation of contralateral limb strength may facilitate post-operative rehabilitation. The various peripheral nerve blockade which are used these days, most commonly is used adductor canal block. Adductor canal block has been for sensory nerve block for post-operative analgesia. The canal is roughly triangular in cross-section and is bound quadriceps anterolaterally and adductor magnus. Within the canal is the femoral artery, the posterior branch of obturator nerve, and branches of the femoral nerve, specifically the saphenous nerve and vestis medialis. The main advantage of adductor canal block is preserving or minimum quadriceps strength that facilitates ambulating and rehabilitation after knee surgery. This is the positioning of the patient for giving adductor canal block. In this picture, we can see there is adductor longus in the on the medial side, vastus medialis laterally, and superiorly the roof is by sartorius muscle. The other block which can be used is femoral nerve block. Femoral nerve block is usually given just below the inguinal crease and 1 centimeter lateral to the femoral artery pulsation. The disadvantage of femoral nerve block is that there might be quadriceps paresis which can be seen. Therefore, it is difficult for patient to ambulate post-operatively. Sciatic nerve block can also be given, but since sciatic nerve block can provide blockade only on the posterior side of the capsule, it has to be given along with femoral nerve block. APPEC is the other block, which is a block given in interspace between popliteal artery and the capsule of posterior knee. This also provides analgesia on the posterior aspect of the knee capsule. The recently new techniques like liposomal bupivacaine is also thought to overcome the limitation of bupivacaine by enabling a slower release of anesthetic. It is an analgesic consisting of bupivacaine hydrochloride encapsulated within multiple non-concentric lipid bilayers. Release of the drug is slow because of the mechanism required for the bupivacaine to escape from its encapsulated vesicles. And once released, bupivacaine acts to block the conduction of nociceptive stimuli. But this liposomal bupivacaine is still not FDA approved. Post-operatively, our main concerns for TKR surgeries will be providing multimodal analgesia. Since orthopedic procedures involve bone cutting, it can be very painful for the patient. We have to watch for the signs of pulmonary embolism post-operatively. It can, patient can experience signs of pulmonary embolism 24 to 72 hours post-surgery. Legs should be kept in abducted position to prevent implant displacement. Since most of these patients are of geriatric age group, post-operative delirium is one of our main concern. And our aim should be to minimize the side effects, early rehabilitation, and patient satisfaction. To conclude, geriatric patients for joint replacement surgeries offer a great challenge to the anesthetist. careful preoperative examination, optimization, safe intraoperative anesthetic technique, good postoperative analgesia, good post-op follow-up would aid in decreasing morbidity in these patients. Thank you.
So thank you, Dr. Sakshi, and I would be glad if there are any questions.
No, ma'am, there are
Dr.
no
Namita?
questions.
Okay, so that brings us to the end of this talk, and I would like to thank again Dr. Kaur, Dr. Nirja, and other members of the team, Akhilesh and others, and you also, Namita.
Thank you, ma'am.
Thank you very much.
Thank you so much, ma'am. Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you.
Thank you, Sakshi.
Now we'll move on to the next session. Now we'll move on to the next session. Before moving on to the next session, I would like to announce the winner of the quiz for yesterday. The winner is Dr. Akshay Kumar from VMMC Safdarjung. As a reward, we will be reimbursing the registration fees for Dr. Akshay Kumar. The next session is again the drug viva. Gurmeet, can I have the CV slide? The next session is drug viva, which will be conducted for the drugs, local anesthetic. And the examiner will be Dr. Akhilesh Gupta, who is Professor Anesthesia in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. His area of interest are pain management and airway. I welcome you, sir.